Journal Club by our institution, Department of Neonatology, IPGMER and SSKM Hospital, Kolkata, West Bengal. Journal Effect of Minimally Invasive Surfactant Therapy for versus sham treatment on death or bronchopulmonary dysplasia in preterm infants with respiratory distress syndrome, the Optimist A randomized clinical trial. Publication accepted, publication number 18 2021. And impact factor for these are journal was 56.7272 for the year 2022. Side of the trial: United States, Australia, Israel, New Zealand, Slovenia, and Turkey. Ethical clearance approval obtained from the Human Research Ethics Committee at its site. An independent data and safety monitoring committee reviewed the interim analysis for safety and efficacy. Trial was registered. Findings support the Royal Hobart Hospital and the Australian National Health and Medical Research Council. However, they have no role in the design, conduct of the study, collection, management, analysis, and interpretation of the data, preparation, review, or approval of the manuscript or decision, submit the manuscript for publication. Time period of the trial: enrollment took place between December 16, 2011 and March 26, 2020. Follow-up was completed on December 2, 2020. Background: NIV rather than invasive ventilation with the expectation of equivalent of better outcomes, including a reduction in the risk of BPD. A meta-analysis of data from clinical trials in preterm infants with gestational less than 30 weeks showed an association favoring a initial CPAP with a relative risk 0.91. In this trial, exogenous surfactant, which is a proven therapy for RDS, was only administered in the CPAP group with relatively high threshold, FI to 40 to 60%. It remains unclear whether the benefit of initial CPAP or respiratory outcomes if surfactant had been selectively administered at a lower FI to threshold in infants with RDS. CPAP alone often fails to provide sufficient support in such cases, and in a large non-randomized study, this pathway of delayed intubation was associated with deleterious consequences, including an increased risk of death or BPD. Among numerous less invasive alternatives, intratracheal administration of surfactant via thin catheter has emerged as practicable and propitious solution, but the benefits of this approach, including relation to death or BPD, remain uncertain. The Optimist trial, one of the collaborative prior trials investigating minimally invasive surfactant therapy, tested the hypothesis that administering surfactant via thin catheter would reduce the incidence of the composite outcome of death or BPD or its components. Aims of the study: to assess composite outcome of BPD of death, CPAP, or if CPAP combined with mist at a lower FI2 threshold with prominent features of RDS. Study design: this is an investigator-initiated international multicentric randomized clinical trial of blinded intervention. Participants: all infants with gestational age 25 to 28 completed weeks in the study center during the time period. Prior administration of saline was expected as part of management but not localized. Inclusion criteria: gestational age 25 to 28 weeks, recurring CPAP, CPAP pressure 5 to 8 centimeter, about to more or equal to 30%, less than 6 hours. Agreement of treating physician in the charts of infants care, signed parental consent. Exclusion criteria: previously intubated or in imminent need of intubation, congenital anomaly or condition that might adversely affect breathing, identified alternative cause for respiratory distress, lack of ability of an optimist team. Randomization undertaken by a treatment team comprising staff not currently involved in the infant's care. Infants were randomized 1:1 to the mixed group or the sham treatment controlled by a computer-generated code link to corresponding OPEX shield envelope. The randomization sequence used permuted block sizes of 2, 4, 6 with stratification by study center and gestational age. Multiple parts were randomized independently. Clinicians and parents were blinded to the study center intervention with the screening of the infants from external view. This is the meshed procedure. Infants in both groups were intubated if requirement of FIO to more or equal to 45%. Outcome measures. Primary outcome, death or physiological BPD. Secondary outcomes measure morbidity and defined as one or more of BPD, grade 3 or 4 IBS, PBL or ROP more than stage 2, pneumothorax, duration of respiratory support, duration of bradycardia or hypoxemia during the intervention, discomfort during intervention, hospitalization code, statistical analysis, sample size. The study aimed to recruit 606 infants, providing 90% power to detect an absolute risk reduction of 13%, RR reduction of 33% in the incidence of death of BPD, which for the control group was projected to be 38% based on observational data. For the primary outcome or its components, the RR comparing active treatment with control was estimated according to a randomization group using a generalized linear model adjusting for gestational strata. Since sensitivity analysis for the primary outcome or its components were conducted for the as-treated and per protocol populations. For other outcomes, the RRs for and mean differences were estimated using generalized linear model. Pre-planned exploratory subgroup analysis were performed for the primary and other pre-spread outcomes by gestational strata, age strata, FIO requirements, and geographic regions. Results console diagram for participant follow through the study. 5187 infant gestational age 25 to 28 weeks, screened for enrollment, 33 centers. And out of this 92 eligible for enrollment, out of this 4488 randomized. Baseline characteristics both groups are comparable. However, the frequency of male sex incomplete or no steroid exposure and multiple parts within the gestational stage 25 to 28 weeks where is 12 to 14% higher in the mixed group. For primary outcome analysis, death or bronchopulmonary dysplasia, death prior to 36 weeks PMA and bronchopulmonary dysplasia 36 weeks PMA. P value is not a significant primary outcome. So death or BPD as 36 PMA occurred 43.6% in the mixed group and 49% in the control group. Death occurred prior to 36 week PMA in 10% in the mixed group and 7.8% in the control group. The incidence of BPD in survivor was reduced in the mixed group 37.3% versus control group 45.3%. Pre-specific clinical outcomes out of 6 pneumothorax recurrent drainage and need for intubation within 72 hours was statistically significant, reduced. For secondary outcomes, the need for intubation within 72 hours of birth was reduced in the mixed group. The cumulative proportion for infants requiring intubation in the two groups diverged during the first 24 hours. Significant differences favoring the mixed group are noted for 4 out of 15 binary secondary outcomes. Treatment with mixed was associated with reduced requirement for intubation, incidence of PTA requiring medical therapy, and need for oxygen therapy at home in survivors to hospital discharge. The mixed group showed a reduction in 6 continuous secondary outcomes, quantifying duration of therapy, mechanical ventilation 1 day versus 4 days, mechanical ventilation plus CPAP 25 days versus 32 days, and all forms of mechanical respiratory support. Subgroup analysis showed there was a statistically significant interaction relation to the treatment effect. Control group favored at a lower gestational age and mixed group favored a higher gestational age. Subgroup analysis for the secondary outcomes, the pattern of treatment effects did not appear differ between gestational strata. In the incidence of primary outcomes and its components varied considerably in the control group between geographic regions, but there was no statistically significant interaction in the effect of mixed across the regions. Exploratory outcome, trachea was catheterized during the first attempt 76% in the mixed interventions. Hypoxemia and bradycardia were common but transient, with positive pressure ventilation applied 40% cases and emergent intervention in the one infant. A total of 54 serious adverse events were reported, which were evenly distributed, 10.3% in the mixed group and 11.1% in the control group. Discussion. Analysis components of primary outcome showed an absolute increase in death 2% prior to 36 weeks PMA favoring control group, which was not statistically significant. There was an absolute decrease 8% in BPD survivors to 36 weeks PMA, and effect of missed on the incidence of BPD prosecuted over observed reduction in exposure positive pressure ventilations. With a larger sample size, blinded intervention, protocolous intubation threshold, the present study provides more robust definitive evidence regarding this method of surfactant delivery. Our cognitive review of head-to-head trials of surfactant delivery via thin catheter or ET has provided strong evidence in favor of the catheter delivery method for death BPD. A limitation of the study. First, after solo recruitment, enrollment ceased at onset of COVID-19 pandemic at 81%. The pre-planned recruitment target, meaning that the study was underpowered to detect the treatment effect of the magnitude originally hypothesized. Second, on data on numerous clinically relevant outcomes were collected and multiple statistical components were performed, raising the possibility of type 1 error. Third, although the intervention was successfully blinded to the treating clinicians, members of the treatment teams are likely to have participated in the care of enrolling infants at some time during the hospitalization, raising the possibility of performance bias. So conclusions, among preterm infants with RDS supported with CPAP mixed compared with sham, did not significantly reduce the incidence of the composite outcome of death or BPD at 36 PMA. However, given the statistical uncertainty reflected in 95% confidence interval, a clinically important impact cannot be excluded. Critical appraisal skills programs. Did the trial address a clearly focused issue? Yes. Was the assignment of the patient to the intervention randomized? Yes. Were the patients who entered the trial properly accounted for the conclusion? Yes. Were patients health workers or study personnel banded? No. Were the groups similar at the start of varsity? Yes. Apart from experimental nutrition, were the groups treated equally? Yes. Were the effects of intervention reported comprehensively? Yes. Was the precision of estimate of the intervention or treatment effect reported? Yes. Do the benefits of experimental intervention outweigh the harms and cost? Yes. Can the results be applied to a local population in your context? Yes. Would the experimental intervention provide greater value to the people in your care than any existing intervention? Yes. There is optimist trial. Now, regarding optimist trial, study participants will be 29 to 32 weeks. Entry and exclusion criteria will be the same. Intervention will be same, except for the doses. Doses will be 100 milligram per kg of Kirosap. Post-intervention management, other than requirement to other intubation criteria, management after intubation will be at a discretion of the clinical team. Primary outcome will be duration of respiratory support, intubation CPAP or high flow nasal cannula. Secondary outcomes, incidence of death, major knee injury, morbidities. Sample size will be 448 infants, 2 to 4 per group. Trial plan, large scale funding is being short for the optimist trial, and the trial will not commence until such funding has been